comes out with an EKG every week that I normally do. Life in the Fast Lane and WikiEM. They're all very good resources. Is that any other questions? You want me to send the PowerPoint to you, or
Okay, maybe I will transfer.
and then you can send it to them? But I'm gonna do another EKG lecture next week for the residents. If you want to do another EKG, I have some the book with questions. And we're going to go over like super common, or if you want to do it right now for a little bit.
Yeah, sure. Still have time, 15 minutes?
15 minutes, yeah. Y'all can, somebody can take turns coming up here and trying, maybe? Somebody brave? Alright, who wants to come up and give it a shot? Anybody? You want to come up here and give it a try?
Yeah.
Nobody?
It's gonna be nice.
Alright, so let's just, you want me to just go step by step? So rate? Actually, we'll just go that. Rate? What do you think of on the rate?
Around
75 to 60. Yeah, perfect. Rhythm? What do you think about rhythm? We'll just go around. Science rhythm, good. Positive and 2, negative and ADR. What do you think about axis? Axis, so positive and 1 and positive and ADF. It's the same axis, it's positive and 1. So it will be somewhere here. Positive and ABF, somewhere here. So it's normal axis. Rate rhythm axis. PR, what do you think about PR? Normal, okay. QRS, narrow complex. Then QT, less than half the R to R. And then I go QT and ST and T segment. ST is okay, T segment, T wave inversion V1 is normal. ST is, we have an elevation. T wave is normal. ST elevation, ST elevation, ST elevation, ST elevation, ST elevation, normal. Maybe a little ST elevation and normal. So we have kind of ST elevation everywhere, right? So, you might be concerned about pericarditis, right? And you might also be concerned about benign early reflow. You know, so you can see here he has got notching in the ABF here. This is actually just benign early repolarization.
What will you do for this patient?
Nothing.
Nothing?
No.
You let them some tags or echo?
No. Send him home.
Sure, because this patient comes to the hospital because of chest pain.
Yeah, but we have a cause. Lifting weights. He was lifting weights.
So do we need any other test for that patient?
No.
Just the AKG?
Just EKG. You might get one set of troponin. One set, and then send him home. Maybe one set. But what are the chances of him at 24-year-old having coronary artery disease is
Rare.
0%. You know, pericarditis maybe. Pericarditis you treat with NSAIDs and muscle strain. You treat with NSAIDs, so you can send him home with ibuprofen. Either way, but anybody who comes in with chest pain needs an EKG. Regardless, they could be in. He could have Wolff Parkinson White. He could have, you know, one of those other things that you should look for also.
How the youngest your patient you have ever met with STEMI?
30.
Okay, and here the youngest patient STEMI I have seen here 28,
Very big.
not too big. Look like this guy. Bigger a little bit. 28 years old.
That's scary.
Yeah.
So maybe. So still maybe, I guess. So what do you guys think about this one? Rate?
100.
300, 150, 100. Rhythm? Sinus. P upright. P down in ABR. Axis? Maybe one is you don't know. Could be either way.
Could be positive.
ABF is can't tell.
I mean, it's same with the way D1, 0 to 3, is still normal.
Maybe so and maybe normal, maybe 0 degrees. And PR.
Maybe 1 degree.
A little bit, yeah. First degree. PR is a little long. QRS. From here to here. A little long. And QT. T-wave inversion, T-wave inversion, T-wave inversion. Everything else looks kind of okay. ST T-wave is okay, ST T-wave is okay, and ST and T-wave is okay. So what do you think? Yeah, right, just to do a block. So you have RSR prime. Do you know what else goes with a right bundle branch law? Slurred S wave and V6. See here? Now the S wave is very slow to come back up. So some people might look at here and here, they think it looks unusual, right? But actually this whole thing is all QRS, okay? Some people might think this is ST depression, but the ST segment doesn't start until right here. Because you know that this is, this wide, so in all the leads, the QRS is that wide. So your ST segment doesn't start till here. Does that make sense? And the other thing to remember with right bundle branch block is T-wave inversion is normal in V1, V2, and V3. So these T-wave inversions are not unusual. Now, say somebody comes in with a right bundle branch block, he's 55 years old, and he has chest pain. How do you look for myocardial infarction? Is it the same, different? Can you look the same way as a normal EKG?
Maybe analyze infarct.
So you still look the same way, okay? You still look for ST elevation, okay, and reciprocal changes. Okay. So do you know where to? I have a little mnemonic to show you where to look for reciprocal changes. So if you have ST elevation, do you always look at it by the leads? You know, you have one AVL. There's one area, V1 through V6 is another area, 2, 3, and AVF is another area, okay? And say you see ST elevation in any one of these areas, you have to look for ST depression or T-wave inversion in another area, right? So there's a mnemonic that helps you remember where to look. Okay? So if you have a posterior infarction, you look in the anterior leads for reciprocal changes. If you have an anterior infarction, you look in the inferior leads for reciprocal changes. If you have an inferior infarction, you look at the lateral leads. If you have a lateral infarction, you look at the septal leads. So it's 1 AVL, AVR, 2, 3 AVF, and then V1, V2, V3, V4, V5, V6. This is your septal leads. Septal. These are your anterior leads, V3 and V4. Anterior, and then these are your lateral leads. Okay. These two are your high lateral leads, and these are your inferior leads. Should commit this to memory. All these together are called your precordial leads. So if you have a infarction in here, you think maybe LAD. Okay. You have inferior leads. You think left anterior descending. You might be concerned about, for your inferior leads, right coronary artery, and this one could be left circumflex, maybe. Okay. So those are kind of the distributions, and I think I gotta leave soon. So do you think we can do one more? We can do one more. Alright, so what do you guys think about this one? Erase. Rate. $300, 150, 175, yeah, maybe 80. Rhythm. Yeah. Sinus. What do you think about axis? Left axis. Good. And what do you think about? How do you do axis? So 1. You know it's on this side, positive and 1. ABF is negative, right? So it's up here. That means it makes it in that quadrant. Intervals, long PR, definitely long PR intervals, long QRS, and QT is okay, right? Now, what is your differential diagnosis for wide QRS complex? Bundle branch block. Complete block, bundle branch block. So you look at this wide complex and you think probably going to be a bundle branch block. Okay. You have the RSR kind of mountain over in D6, and you have. Just remember how this looks, okay? Because that is how a left bundle branch block looks. So this is just a left bundle branch block. So he increased his dose, 82-year-old man increased his dose for beta blocking medications. And that's why he has a prolonged PR interval. Because remember the PR is the AV node. The time it takes to cross the AV node. Beta blockers work to slow down the AV node. The other thing you can see with left bundle branch block is a monophasic R wave in lead 1, which he has a single large monophasic R wave in lead 1. And then you look for ischemia differently in a left bundle branch block, which probably is going to be too long to go over. It's called Scarbosa criteria, if you want to look it up. Actually, you could see the kind of RSR on V5 and V4, but we can go over Scarbosa next time if you like. I think that's probably good for now. Any questions?
So in this patient, do we diagnose it on AV block?
Yes, first degree AV block. Also, if this is a 82-year-old gentleman and he has chest pain, and he comes in with, and you have an old EKG from 2 years ago with no left bundle branch block, he has a new left bundle branch block, you want to call cardiology. They may want to take him to cardiac cath right away. It used to be before 2013, new left bundle branch block was a STEMI equivalent. So that means it equals ST elevation, used to be. They, since 2013, changed it, but if you see a left bundle branch block that's new, very, very concerning for ischemia, and you should be on the phone with cardiology to see, especially if they have very typical symptoms like diaphoresis, sweating, and chest pain that sits on the top of the chest, pressure. So that's kind of a big thing to remember.
How about the right
No, right bundle branch block is very normal, especially for an older patient. Very common to get right bundle branch, not as much for left bundle. Then you would just look for the ST elevation still. They may need a stress test if they have a lot of risk factors, but that one doesn't.
Is that acute coronary syndrome?
Well, that's what I'm saying. If they have a story that is concerning, then they should stay for a stress test anyways, or to see cardiology. But that by itself doesn't make you concerned about coronary artery. Just, I don't know why. Old people get right bundle branch block is normal.
What do you think about the term core array in V3.
Yeah. In this one, in this patient right here, or just in general?
In general.
In general, yeah. In general, you flip from V3 to V4, where your R wave gets much larger. But if it's very, very late, it's also concerning for ischemia. But it's not a STEMI equivalent or anything like that. It's still something. More the history is more the most concerning thing. If they sound and they look like they're having a heart attack, then that's the most concerning thing. But yeah, if they sound like it and they have poor R wave progression, then I would try to push cardiology more to take them more, admit them, or possibly do a catheterization.
Yeah.
But it's not a STEMI equivalent. But none of this stuff is perfect. But sometimes these things can add to your suspicion, plus or minus your suspicion for ACS.
And I have a question for the patient with left bundle branch block. And you told us you have a 2 years ago EKG, so no error, left bundle branch blocks.
Yeah.
And now it's error. But the gavels are around 0 point.
Then I would still be concerned. But if it's scarbosa positive, then you definitely they need to get cath right away.
No. But if they're negative,
If it's negative, then I'd still admit them and still be very concerned. Any left bundle branch block. Scarbosa criteria apply for 2 things. I think I accidentally opened this. Left bundle branch block and pacemaker.
But for newly developed left branch, when we use scarbosa.
Still use scarbosa.
For newly developed.
Yes. Anytime they have left bundle branch, you should look at scarbosa. But just having a new left bundle branch is very concerning also, by itself. Good questions. Alright, I think I need to go back.
Will with the double tie
Oh, yeah. Oh, okay. To the
Party tonight?
party.
Okay.
Okay, good. Are we going now?
It's done.
Any other questions? You guys wanna do the rest of them next week? I picked out 13 good ones, kind of classic emergency medicine, classic EKGs you should know. You can send it to you. You can try to figure out what it is before next week. Good?
You will move the first June, right?
Yeah.
So next week you will still time.
Yeah.
Okay, we will discuss with Dr. Jung and about our schedule.
Yeah.
And okay.
Yeah,
On behalf of all participants, we would like to thank you so much for your time.
Yeah, no problem. Thank you. Thanks for having
We
me.
have a interesting evening with the party.
Yeah, hopefully.
Laura?